Alrighty. So thank you for giving me this opportunity to talk. I'm Mike Auriemma, and my colleague, Dr. Nate Yokel, two physicians with Regenerative Orthopedics and Sports Medicine, or ROSM. I'm going to give a brief overview of who it is, who we are as a group, and talk kind of about our approach to treating patients, as well as then dive into regenerative medicine to give some background on these types of procedures and how we utilize them. And then here I'm providing the title of a article written by one of our colleagues, Dr. Sean Mulvaney, in our Annapolis office, that provides a succinct overview of the regenerative treatments that I'll be covering in this PowerPoint. So this is a good reference if you ever want to grab this article as a review or want to refer any of your patients to it for an overview of these treatments. So let's start by providing an overview of who we are as a group. What is it that we do? What does ROSM offer? So we're a relatively small private practice group, primarily focused in the DMV. We have multiple locations in the area. So in Maryland, we've got offices in North Bethesda or Rockville, Columbia, and Annapolis. We have a Tyson's Corner and Reston, Virginia location in Virginia. And then in DC, we have a newer singular office at 1145 19th Street that we consolidated two separate DC offices into this one larger office. And then we have our satellite group out in Boulder, Colorado as well. And all of the docs in our practice are musculoskeletal specialists with additional training in either sports medicine or interventional pain management. We are all 100% non-operative. We do not have any surgeons in our group, though there are surgeons in the area that we have good relationships with and will refer out to when appropriately. In terms of, what is it that we offer that we believe makes us stand out from others? So we truly are a patient-centered group. We spend a considerable amount of time face-to-face with our patients. I would say on average over 30 minutes, which is really unheard of when you think about medical practices that are taking insurance. Because we do believe that listening to the patient and thoroughly examining the patient is the best way to arrive at the ailment that is bothering them. In that time that we spend with the patient, we really do take a comprehensive approach. So when somebody comes in with elbow pain or knee pain, to us, it's not enough to just diagnose the cause of the elbow pain or the knee pain, but it's also to determine, are there other biomechanical factors that are driving that process? So for instance, if they're having tennis elbow in their elbow, do they have an issue approximately up at the shoulder where the shoulder pathology is actually driving aberrant motion through the entirety of the upper extremity, resulting ultimately in the development of the tennis elbow? So we really do take that comprehensive approach and evaluate from a physical exam perspective the entirety of the kinetic chain. I do want to clarify, though, that does not necessarily mean we can do a head-to-toe thorough exam for every patient that comes in each and every visit where they're saying, I've got left shoulder, right elbow, left hip, and right foot pain. We try to be as comprehensive as possible, but at times we do need to parse those out into additional visits in order to not rob Peter to pay Paul and take shortcuts. We also regularly incorporate diagnostic ultrasound to our evaluations. So in addition to examining them physically, we're going to put the ultrasound probe on them and look at their anatomy. And this enables us to get to a more accurate diagnosis in a swifter amount of time. In certain situations, the use of that ultrasound will obviate the need for any potential x-rays or MRIs. Other times it will be complementary to those imaging modalities. In terms of treatments, we really focus on treatments that are aimed at promoting healing and enhancing function. So we're not into the Band-Aid treatments such as a corticosteroid injection just to temporarily reduce pain, but not promote functional recovery and healing over the long term. And a lot of what we offer can provide an alternative to surgery, particularly surgeries that are frankly performed at too high of a volume in this country for conditions that they really are marginally beneficial for at best. Here are some images of examples of different things we can do intervention-wise with ultrasound guidance. So we can perform joint injections where we know for sure the needle is within that joint space. We can inject around tendons or even into tendons if necessary. We can access bursa, bursal spaces throughout the body. And while in this image, while this space is clearly defined right here where you see the needle tip, in actuality, that distance is 1 to 2 millimeters. So when somebody performs a landmark guided or blinded injection without ultrasound guidance and says they're doing a bursa injection, they're probably lucky if they hit the bursa, because you're talking about having to get to something that's about 1 millimeter in thickness. We can do periligamentous injections. We can do perineural injections where we can treat around nerves to free up a nerve that may be entrapped. We can also do percutaneous scar tissue debridements. There's a lot we can do under ultrasound. And probably the sexiest topic in terms of what we can do under ultrasound are the regenerative injections. And we'll focus the remainder of the talk on really defining what regenerative medicine is in the musculoskeletal and orthopedic world. And in order to best define regenerative medicine, it makes sense to first look at what traditional musculoskeletal and orthopedic medicine consists of. Typical orthopedic medicine consists of heavy usage of anti-inflammatories, whether those be NSAIDs like Advil-Aleve or corticosteroids, the use of destructive interventional modalities such as Botox or radiofrequency ablation, and then ultimately surgical options. And each of these approaches, while for specific diagnoses may have a distinct utility, they are quite contradictory in general to the regenerative approach. And there's also a slew of literature that's out that would actually call into question the efficacy of these typically pulled for treatment options. So in terms of NSAIDs, what we know about NSAIDs is that while they may temporarily reduce inflammation and pain, beyond about a 4-week period, they really don't have any long-term efficacy for regular use. And in fact, they actually can, they have not been shown in the literature to provide any benefit for long-term healing of musculoskeletal injuries or recovery. So NSAIDs aren't necessarily our friend when we're talking about more subacute to chronic musculoskeletal issues. In terms of corticosteroids, it's a similar picture in that the steroids are a temporary Band-Aid. They can reduce pain, they can reduce inflammation, and on average, they're going to provide relief for anywhere from a couple of weeks to maybe a couple of months. But they don't provide long-term benefit in the vast majority of cases. And in fact, there are a host of side effects that come with corticosteroid usage. And when we think about the effects of corticosteroids on the joint, this bottom article from 2017 actually showed that over a 2-year follow-up period, patients who underwent a corticosteroid injection into their knee joint for knee arthritis, they actually had further progression of their arthritis over 2 years as compared to the group that was having saline injected into the knee. So really it's running the risk of further progressing that musculoskeletal disorder over time rather than helping. So certainly a contradictory approach to the regenerative approach. And it really shouldn't be surprising that that 2017 article indicated that there would be progression of the arthritis, because we're well aware from previous studies that steroids have chondrotoxicity, and even as little as a single dose of a corticosteroid introduces toxicity both to chondrocytes, which are cartilage cells, and tenocytes, which are tendon cells. In terms of radiofrequency ablation, so this is a pain management technique where catheters are placed along the length of a specific nerve, and the nerve is effectively burned in order to disrupt the pain pathways. But what we need to keep in mind is when you're cooking that nerve, what else does that nerve potentially innervate? And the most common use for this intervention is axial back pain, either of the neck or the low back. And the nerve that's ablated in that case also innervates the multifidi, which are important spine stabilizers. So what you see over time from left to right is fatty infiltration of those spinal stabilizers due to the nerve being cooked and the muscles dying off and atrophying. So if you're going to Whole Foods and looking under the butcher counter, this might look like a good piece of ribeye, but this isn't a spine muscle that's going to fire well and keep somebody strong and stable. And then finally, let's take a look at some of the common orthopedic surgeries. In terms of arthroscopic surgery, arthroscopic meniscus surgery continues to be the most commonly performed arthroscopic orthopedic surgery in the US, despite the fact that there is very questionable efficacy for this surgery, particularly in individuals aged 40 or older with more of what's termed degenerative meniscus tears. If you have a 21, 22-year-old athlete who acutely tears their meniscus while they're playing basketball, et cetera, and that meniscus is observed under MRI to have a clean tear that a surgeon can go in and repair or reconstruct, that repair is a fair approach and something that has acceptable outcomes. But when we're talking about degenerative meniscus tears, despite the fact that these surgeries are still regularly performed, it's really very few and far between the individuals that should be pursuing those surgeries. And those are statements not by non-surgeons, those are statements from major surgical journals as listed right here, including the British Journal of Sports Medicine. So how does regenerative medicine compare to these approaches? And honestly, my preference or preferential term is reparative medicine as opposed to regenerative medicine, just because regenerative to me gives off too much of the connotation of a chameleon or a lizard regrowing its tail. Unfortunately, we don't have any treatment that is that strong. If there was, the line would be out the door nonstop. But we do have treatments that are able to tap into our natural repair mechanisms in order to exert functional improvement and pain improvement. And really the goal of regenerative medicine or reparative medicine is to augment the body's natural or endogenous repair capabilities and really swing the balance from one of tissue breakdown to one of tissue repair. And what we're tapping into, particularly if we're treating tendon or ligament disorders, are these phases of tissue healing, where there's an initial period of inflammation followed by proliferation and finally remodeling. And at the tissue and cellular level, this is a process that usually lasts for anywhere from 4 to 6 days, though can last out to 2 weeks. The proliferative phase is something that starts following inflammation, usually around that 1 week mark, and usually lasts about 2 weeks, but can last out to about a month. And then the remodeling stage can actually last out to a year. And while we can't necessarily speed up this process, what we often find with subacute and chronic musculoskeletal conditions is that for one reason or another, our self-repair mechanisms become stagnant, and that kick in the pants that's required to get somebody back into this process is where we can really come in and help out. So the tools in our armamentarium to accomplish this include proliferative agents like dextrose, which is commonly referred to as prolotherapy, autologous agents, which are substances that come from one's own body, such as PRP or PRGF, or other advanced cellular therapies, which are commonly referred to as stem cells. And we'll get into some of the details regarding all of these in just a bit. And then there are allogeneic treatment options. So that means coming from same species, but a different individual. So this would be an off-the-shelf type product. And really, for the purpose of this presentation, I'm going to focus on the first two because this really makes up the bulk of what we offer. There is far more published in the medical literature on the use of these agents as compared to the allogeneic products. And for potentially down the pipe FDA issues that are likely to arise regarding these allogeneic products, here is really where we spend the majority of our time. So let's start with prolotherapy, which is short for proliferative therapy. This is a technique that's actually been around since about the 1950s. Its initial development was to treat ligamentous laxity, with the idea being, from a theoretical standpoint, that a lot of disc disorders and other spine disorders accrue over time due to the chronic accrual of ligament laxity in the spine. So little dings and dents add up over time, the ligaments become more lax, the spine is able to shift a bit more, and you get this disc degeneration over time. And the way that prolotherapy will target the ligamentous laxity or other musculoskeletal tissue injuries is through an osmotic effect. So dextrose in the prolotherapy is hyperosmolar. And when you introduce that hyperosmolar substance, it causes the rush of fluid from the less osmolar region to the more osmolar region. So basically that encourages fluid to exit or be ripped out of cells in the vicinity of where the injections occurred. It causes those cells then to throw up an injury signal to the body. The body then responds to that, and will allow for the recruitment of different growth factors and healing cells. So in essence, this is a way of tricking the body into re-recognizing an old injury as a new, fresh injury in order to re-stimulate that healing response. In terms of PRP, or platelet-rich plasma, or another name for this is plasma-rich and growth factors, or PRGF. If you really dive down in terms of the nitty-gritty, technically these two terms can refer to slightly different products that are similar by and large, but many individuals will actually use these terms equivocally. For the purpose of this presentation, we will use them equivocally to refer to a process whereby an individual undergoes a blood draw that blood then gets spun in a centrifuge so that you're able to concentrate down the platelets, and in particular, the growth factors that are found in platelets. And then those growth factors can be injected into an area of tissue injury or into a joint with arthritis. The way that PRP or PRGF is believed to work is that the growth factors themselves that you're recruiting through the process of prolotherapy, you're actually directly introducing through PRP or PRGF. And then those growth factors will then serve as a powerful homing beacon themselves for the recruitment of additional growth factors and stem cells in a healing response and a therapeutic response. In terms of the next step up the ladder, we're now looking at advanced cellular therapies. And in the US, that's really looking at two processes, either bone marrow aspirate concentrate or BMAC, or adipose-derived transplants or microfragmented fat. So in both of these processes, you're either performing a bone marrow aspiration to obtain a tissue product from the bone marrow that is relatively rich in stem cells, or you're doing a mini liposuction to pull out fat tissue, which is also rich in stem cells. And after a minimal processing phase where either you're rinsing the product or slightly reducing the size or centrifuging in the case of BMAC, you're then re-injecting this tissue product into an area of the body with a substance that is relatively rich in stem cells. We're just careful around the usage of the term stem cells because overseas, a stem cell procedure may very well refer to a process where a patient has one of these tissue products harvested. They're then sent home and said, hey, take it easy, we'll see you in a bit. And that tissue product is actually further digested or altered in a sense that is not consistent with what the FDA regulations are in the United States. And then ultimately the stem cell product overseas can then be expanded in a culture setting in a lab. And when it has grown to an infinite number or an exponentially higher number, it is then re-injected into the patient at a later date. In the US, the only way a procedure like that can be undertaken is if it's under a specific research study. Otherwise, it's what we're really restricted to is performing procedures that have tissues that are relatively rich in growth in the stem cells. But in terms of the efficacy of these treatments or the clinical effect, it actually isn't just dependent upon the stem cell portion. It's also based on the growth factors and healing cells that are found in these products as well. And in all likelihood, rather than these stem cells acting as a cell that is then differentiating into your desired end target, it's likely serving in what's called a paracrine fashion, where it's again serving as a powerful homing beacon. So to summarize those treatment options between prolotherapy, PRP or PRGF, and then the advanced cellular therapies, you can think of these as all entry ramps onto the same highway system, where the highway system is a repair treatment or reparative treatment. And depending on whether you're starting with prolotherapy or PRGF or an advanced cellular therapy, you're getting on further back or further along that highway and skipping some of the traffic if you jump to something like an advanced cellular therapy. In terms of the published literature to support these treatments, in terms of the basic science, animal studies, as well as clinical studies, one of the big complaints, particularly from individuals outside of those practicing these treatments, is that there's no evidence to support them. And that, quite frankly, just is not true. Are there some issues with the literature? Absolutely. But that's the case with almost all of what we do in medicine. And the intention of this lecture is not to go through the nitty-gritty details of each study, but just by going through titles, I can show you that there are a number of studies that have looked at these different treatments for various areas of the body, showing both clinical effect, safety, as well as the basic science effect. So to say there is no literature to support it is not true. There are some deficiencies in the literature, no doubt. And one of the things that we do in our practice is we don't just jump to these treatments, we provide the proper education regarding these treatments for our patients so that the best decision can be made for an individual. Here's a brief look at some different conditions that can commonly be treated with those different injectable options. So very common is osteoarthritis, and within osteoarthritis, other joint disorders, cartilage degeneration, meniscus degeneration or tears, labral degeneration or tears, whether we're talking about the shoulder or the hip, are potentially amenable to these treatments, as are tendinopathies, whether that be rotator cuff, common extensor tendon, the glute tendons, patellar tendon, Achilles tendon. and then certainly ligament injuries as well. Depending on who you talk to, another treatment that can, by some, will be lumped in with regenerative treatments, others will not list it as such, is something called extracorporeal pulse activation therapy, or EPAT, or another name for this is radial shockwave. And this treatment consists of using a handheld device that through air pressure directs a projectile towards an applicator body. And when that impacts upon the applicator body, it allows for a pressure wave to be transmitted through the skin and into deeper tissue structures at various locations of the body. And there have been numerous basic science studies that have evaluated the effects of these pressure waves on the human body. And there are over 30 different proposed mechanisms from the basic science research in terms of how these pressure waves can have both a regenerative effect on different tissues, such as ligament, fascia, and tendons, as well as alterations on the neuromodulatory systems and how pain is perceived. So this is something else in terms of different treatment options that we offer that can be beneficial for different, in particular, soft tissue injuries. In terms of post-intervention rehab, so none of these treatments that I've listed should be looked at in a vacuum. These are all important parts of a comprehensive approach, and they are going to be most successful when a patient is active and involved in some form of therapeutic exercise. For kind of a generalization, I would say that after most of these treatments in terms of the prolotherapy, the PRGF, or an advanced cellular therapy, there's going to initially be a protection period where we might put a patient on crutches or might have them in a sling. And on average, that's going to last anywhere from 3 days to 3 weeks, with the vast majority of cases being up to about a week, unless we need to use a boot for foot and ankle disorders. Sometimes that can linger out for 2 or 3 weeks afterwards. An exception to this would be the shockwave treatments, which really is just a 24-hour period of relative rest before you can return to activity as tolerated, as long as it's not tremendously worsening their symptoms. After about that 3-week period, we then recommend that patients return to working with a physical therapist, or in some cases, if the personal trainer is comfortable with the therapeutic exercise approach, you can return to the personal trainer and really allow the personal trainer to guide that therapeutic exercise. And we're happy to have open lines of communication to assist with that. What should be noted here, though, is that if a patient has either their upper or lower extremity treated, oftentimes, depending upon their early pain level, even though we're protecting things for up to 3 weeks, they're still eligible to cross-train and can train the opposite half of the body, sometimes with some modifications, other times with no modifications. So it doesn't mean that they're laid up in a couch potato for those 3 weeks. The general tenet here with therapeutic exercise following these treatments is that there should be a slow, steady progression. So we're not going to jump them back to where they most recently left off. And you really have to view these treatments as a long-term investment. So the biggest downside in my estimation to any of these treatments is that they are not covered by insurance. So they are out-of-pocket expenses. And if a patient makes a decision that this is this is the appropriate next step for them based on our input, then they really want to make sure it works, and we want it to work, and we want to have all of our ducks in a row to give it the best chance to work. So there is no magic bullet. There is no panacea. There's nothing where you snap your fingers and overnight you're better. It takes time to progress through those repair mechanisms, and it should be looked at as a long-term investment. So in summary, and after this, we'll open it up and take any questions that anybody has. Think of these options as more reparative in nature. Oftentimes, they can help patients avoid unnecessary surgeries. Compared to surgery, there are generally less restrictions and less downtime. We very often will be able to get patients back to the activity they want to return to sooner than the comparable surgery. And really, the goal here is to help patients either return to or at least have the option of returning to an active lifestyle, because that's really what we're passionate about. Take off the screen share now. And we will open it up to any questions.
Excellent talk, Michael.
Thank you.
Yes, thank you. I will, I guess, start one off. I understand that, because I'm taking my video off. This is a different option outside of surgery. What is the percentage, if you can't even give that, if someone was to come in first before going to see a surgeon, that you have treatment that they can do instead of doing surgery?
That's very individual and diagnosis specific.
Yeah.
So again, I think one of the important things to note is that this is not a magic bullet. So if somebody has, let's say, a full thickness tendon tear, and for the purposes of this example, let's say it's a rotator cuff. So if somebody has a full thickness rotator cuff tendon tear and there is retraction where that tendon has separated, these are not a good option because there's no way to physically pull that tendon back together just by injecting into the open space. If somebody finds themselves in that situation and either has a medical comorbidity that does not allow them to undergo surgery, or they are just adamant, no matter what, they're not going to undergo surgery, they can reasonably try that option, but their prognosis is going to be much lower. Versus if somebody has tendinosis or small partial tearing, that's where we're going to treat. And really, that's where these treatments are at least as effective, if not more effective, than the surgical alternatives, particularly when you factor in the length of time that somebody is going to require the rehab and the recovery after surgery. Results aren't stellar for arthroscopic repair of a partial rotator cuff tear, and the rehab is 6 to 12 months before they really feel like themselves. So those are, it really, to answer your question, it really depends on the pathology, not to mention the patient's goals. You know, there's a far different situation if somebody is a couch potato, though they're probably not seeing you guys anyway. But if someone's a couch potato and just wants pain relief when they're sitting on the couch versus somebody who's trying to engage in active modalities and exercise, there's a much different expectation level and functional goal to return to. So I would say it's individualized based on the person and based on the pathology.
Just to add a little bit to that, I think that the other thing that everybody can realize is that you may not know, is this a surgical issue? Is this not? You may want us to be your second opinion before you go for a planned surgery, or a first opinion to see, do I even need to see a surgeon? Is this something that is appropriate to be treated surgically? A lot of times when we do these treatments, especially when it's something that was more wear and tear rather than abrupt injury, you know, if we treat that rotator cuff tear, we're not going to just treat the tear. We want to treat the areas of weakness in your shoulder girdle or your back that led to the rubbing, that led to the pinching. Kind of in the same way when you're working with your trainer, it may be a lot about back strengthening, even though your pain is in the shoulder. We're kind of attacking things the same way. And so when we're doing these treatments, we're not putting all of our eggs in the one basket of that injury. We're also trying to go after the process that led to it. And I think for any condition, it can always be helpful to hear the other side of the street, either a surgeon's counterpoint to our proposal or vice versa, as you're making this relatively, you know, life-changing decision.
Awesome. Brendan had a question on the chat, so I did have an option for them to ask questions there. He wanted to know if you could say a few more words about the use of NSAIDs, and do they have a place in the healing process, or are they just used for pain management?
Yeah, they by and large are just used for pain management. So let's say, you know, there's two sides of the coin for this. Let's say somebody acutely sprains their ankle. We know that first stage of response to that is going to be some degree of inflammation. That's why it swells. That's why it bruises. That's why there's bleeding into that tissue injury. And kind of typical, you know, traditional management of that is, you know, your price, right? You're going to rest it, ice, compression, elevation. You might take some NSAIDs. NSAIDs are going to, you know, reduce some of the inflammation with that, and it's going to help with the pain. But at the same time, is that potentially going to impair some of an individual's natural repair mechanism? There's certainly that risk. But temporary short-term use of an NSAID, I'm not against it in those situations. Or you intermittently have headaches, you take an Advil or an Aleve, you feel better. There's no qualms with that. But the idea that I have knee arthritis and I'm going to take 800 milligrams of Advil 3 times a day for the rest of my life, that's not good medicine. First off, while inflammation is a component of most cases of osteoarthritis, it is not the primary driver of osteoarthritis or the primary pathophysiology. And then you think about the long-term ramifications on the kidneys and on the heart from regular long-term NSAID use. It's not helping the patient in the long term. So sporadic usage, I don't have a problem with. There are situations where I will actually encourage a short bout of an NSAID. I might say, hey, this really looks inflammatory. Why don't we do 3 to 5 to really on the long end for me, it's 7 days of regular scheduled NSAID use. And then we stop afterwards. If somebody has a hot disc that you think that they've herniated a disc and they're having hot radicular symptoms, that's a case to use some form of an anti-inflammatory, whether it be a steroid dose pack, a steroid injection, or even an NSAID. But the long-term efficacy, there really isn't a strong role for that. And around these treatments we're talking about, we will generally have patients hold any NSAIDs that they're using for 7 days before, as well as a minimum of 10 days afterwards, ideally 30 days afterwards, because we don't want to shortchange the pro-inflammatory response that we're somewhat encouraging through the treatment. Nate, do you have anything you would add to that?
I think that's spot on. I think the idea of calming things down so you can move more normally, so you don't put stress on other areas, so we can decrease some of the excessive swelling that is causing serious, terrible acute pain, that's an appropriate use for it when we need to. To use it in a long period is probably muting your body's ability to heal and remodel itself, not just in the area of the injury, but the rest of your body. So a lot of times we will kind of transition to topical treatments where you can put some of those same medications that you may want to take by mouth, anti-inflammatories, numbing medication, muscle relaxants, but directly on the area that is affected to calm that down without messing with the rest of your system and kind of body mechanics. But I would agree that it's not like we never use them. We just use them judiciously. Where people have a problem is that they use it as a long-term treatment. I think in all fields of medicine, we're trying to get away from that. And I think, even the orthopedic world is starting to realize that this is not the best plan. If we're calming it down and not fixing it, it's going to continue to linger. But the idea that it's doing anything to heal it, that's absolutely not true. It's only calming inflammation.
Yeah. And a quick clarification too. When we're making these statements, we are not including rheumatologic disorders with this. A rheumatologic disorder that is inflammatory by nature, typically rheumatologists are managing those, not us. And there clearly is a role there from a mechanistic standpoint for an anti-inflammatory. That's distinctly different from what we're talking about.
Yeah, good point.
Anything else question-wise? So what's a hot disc? So I'm sorry, I just opened up the chat there. So I'm referring to an acute herniation. So if somebody acutely herniates a disc either in their neck or their low back, and they're getting that stereotypical burning pain, numbness, tingling down a distribution of a nerve root down the back of their thigh to their calf, what's commonly referred to as sciatica. That's generally, there's generally an inflammatory component to that, whether the disc is mechanically pushing on the nerve root or not. So hot disc is referring to kind of acute onset disc herniation, lumbar or cervical radiculopathy, radiculitis symptoms, nerve root irritation. So looking at the next one that's popping up. Yes, there is varying success rates based on area of the body. So if we're just talking about osteoarthritis, there are certainly, there tends to be better success with the knees than there are hips. And that's what the medical literature would support as well. Within a given joint though, there's also going to be varying levels of success based off of how severe versus how mild the process is at this point. And in general, more mild to moderate arthritis is likely to be more successful with these treatments than more moderate to severe. If they have bone-on-bone arthritis, that you're looking at something that is much more challenging to treat from a non-surgical perspective. In terms of tendon disorders, again, it's looking more at the tendinosis or small partial tears versus full thickness tears is where we see the difference. There's stronger evidence to support the use of these injectables with glute tendinopathy than there is with rotator cuff tendinopathy if we just do a one-to-one comparison. But again, it's really, from our perspective, one of the things that really plays into the potential success or failure of these treatments is starting off with that comprehensive examination so that we're not missing aspects that are contributing to a patient's presentation, so that when we go in, and excuse the colorful analogy, we're going in to nuke the village. We're not trying to go in and just pick off one little spot. We want to hit everything that is potentially contributing so that we give somebody the best chance of a successful outcome.
And to add to that, I think that when we're looking at these different parts of the body, a lot of the studies in the literature is looking at one time or a series of injections only in the joint space, or looking at an injection only in the tendon. We very rarely will do that in our practice. I think our practice is a little unique in the way that we are using ultrasound to guide these treatments and using our physical exam to look at all the supporting structures. I think part of the reason we're getting more favorable results is that more complete treatment that Dr. Auriemma is referring to, where if somebody has knee arthritis, we're not just putting all of it into the joint, we're also treating the supportive ligaments and tendons. We're saying, well, your knee started wearing down because of weakness in your foot and ankle, weakness in your lower back and hips, and trying to treat those as a unit. When we're treating someone's hip arthritis, we're not just treating that joint, we're treating the gluteal tendons and sacroiliac joint and ligaments to play off of it. And so I think we can increase our success rate by being more complete in our treatments, and various injuries will have different response rate to different kinds of regenerative treatments. So lower grade arthritis, the results between plasma and bone marrow treatments are pretty similar. When you get to grade 3 and 4 arthritis, bone marrow and adipose treatments outperform the plasma by far. And so as you kind of have a different area, there may be different success rates. But I think our goal for all of our patients is to give them all the options and let them know whether we think it will help or not. We will often tell patients if we think this doesn't have a great chance for success. Doesn't mean that we won't do it if they don't have other options, they have other medical reasons why they don't want to, or they really want to try this first. But we really try and give people a heads up in the beginning whether we think it's a good likelihood success or not, and try to be very complete with our explanation of what you're getting into.
Yeah, I would add too to that we really do take pride in that being one of the things that we think separates us from a lot of providers in this space. We're not here to push these procedures on anybody. We want to perform them in a judicious manner, an appropriate manner, and really educate patients on do we think that this is a viable option for them, or do we think that it's really a Hail Mary? So we really want to be we really want to be caretakers of this technology and these treatment techniques, because they can be very, very useful. They also can be misused. And unfortunately, the big headlines that work their way into the news is when they get misused. I mean, cases in Florida where a chiropractic office was injecting them into the eyeball. I mean, crazy stuff. So.
I have another just random question as my dog is falling asleep over here. Interesting talk though. But I know that, there's a lot of dog lovers around here. Are these being used in animals?
They are. They're used extensively in animals. So there's a big veterinary practice called ROSM, Regenerative Orthopedics Sports Medicine, who one of our founding partners, Dr. Victor Ibrahim, had previously did some research with the practice owner of ROSM. A lot of the research or initial research came from animal models, and these are used extensively in dogs and horses in particular. So it's pet lovers will oftentimes spare at no expense for their companions. So it's done very, very, very regularly. Probably, I don't know, Nate, I would almost gather to say that it's done with higher frequency in animals than in people.
I think as far as animal owners that are aware of it, absolutely. I think the horse racing industry is one of the pioneers of these plasma treatments, using these treatments for horses where if they have an operation, that's it for them, and to kind of keep them moving. A lot of transitional research has been done between the veterinary and animal world, and there's a lot less restrictions from governing agencies about what you're allowed to test on animals. And so when they're doing a procedure, say for instance, an adipose graft for an ACL injury of a dog, they will do a post treatment arthroscopy to go in and look and see that repair. They have some amazing before and after pictures, where in a person, if they're doing well in their knee, the last thing they want you to do is go in and operate just to take some pictures. And so we've learned a lot from working with them. When our physicians first come on, we'll have them rotate out and spend some time with the VOSM group and kind of see what they're doing. And, you know, we're looking at continuing to kind of collaborate on research projects going forward. So there's absolutely a lot of overlap in what we do. I would say, if anything, they're probably a little bit ahead of the animal world in some areas. And our practice in specifically has some strong association with some of the local groups. And anybody with a poor dog, cat, horse that's having some joint issues, definitely check out the VOSM website.
Thanks everyone for joining. You guys have a wonderful day.
Wonderful.